Welcome to week 4 of the Lymphoma Management course. My name is Dr. Toby Eyre. I'm a consultant haematologist in Oxford. And this week we're going to be talking about indolent lymphoma, and I'm going to be kicking off talking about the management of mantle cell lymphoma. So mantle cell lymphoma is a unique subcategory of B-cell non-Hodgkin lymphoma. It's often aggressive but quite heterogeneous in its behavior and is approximately 5 to 6% of all adult non-Hodgkin lymphoma in the Western world. It's higher in Caucasians than other ethnicities, and its median age of onset is about 68, although clearly some variability there. It's a disease that is predominantly seen in males for reasons not well understood. And the disease biologically is characterized by cell cycle dysregulation, genomic instability, and the importance of the B-cell receptor pathway signaling. The T1114, so the translocation of the immunoglobulin gene to cyclin D1, is characteristic and often important in the diagnosis. It's strongly CD20 positive, often CD5 positive, and cyclin D1 positive, as you can see on the right-hand side of this slide. So I'm going to talk through frontline management first, talking initially about the evidence for stem cell transplant, move on to the relapse setting, and talk about novel agents at the end of this talk. So the evidence for stem cell transplant is highlighted in this slide. It's a historical slide, really, going back to 2005, a randomized study where patients were induced with the CHOP-like induction and randomized to further CHOP and maintenance, or a TBI cyclo autologous stem cell transplant. This is in the pre-rituximab era, and you can see here that there was a progression-free survival advantage for those receiving autologous stem cell transplant. There were some patients that did receive rituximab here in induction. Actually, in that subgroup, there was no benefit to autologous stem cell transplant with long-term follow-up. So the evidence really for stem cell transplant is this and phase 2 data. Here's an example of the phase 2 studies that exist. So this is the MCL2 study, really demonstrating the efficacy of a regime called the Nordic approach, where high-dose cytarabine is alternated with R-CHOP given at higher doses, as you can see there, so maxi-CHOP doses. Patients stem cell mobilize after the final cycle, after the 6th cycle, and then are treated with an autologous stem cell transplant. This study, the MCL2 study, was compared to the MCL1 study. So this is not a randomized comparison here for event-free survival and so forth, but you can see here a substantial uplift. The introduction here of cytarabine and rituximab here resulted in this improvement against historical controls. There are other regimes that have been investigated, and this is a randomized study by the European Mantle Cell Lymphoma Network, testing the addition of high-dose cytarabine here into the induction. So patients were randomized between R-CHOP induction versus R-CHOP alternating with R-DHAP. And this study demonstrated with the first follow-up an improvement in progression-free survival. Patients in both arms who responded went on to autologous stem cell transplant. So this study really showed the importance of high-dose cytarabine in the induction for younger, fitter patients. The long-term follow-up has been presented at ASH in 2021 and has demonstrated when patients are adjusted for the MIPI and the Ki-67, an improvement in 10-year overall survival in the R-DHAP containing arm. So really showing the importance of cytarabine in the induction. That's the critical agent to use in younger patients. The other really important agent to use in induction is rituximab and also post-autologous stem cell transplant. This is the first readouts published some years ago now of the French study, the Lima study, where patients were randomized after induction and after autologous stem cell transplant between observation or maintenance rituximab, in this study given every 2 months for 3 years intravenously. And you can see at this first readout, there was a substantial event-free survival and a statistically significant overall survival benefit. This data has actually been updated and presented this summer and has shown approximately 30% progression-free survival difference, event-free survival difference, at 7-year follow-up. So really a substantial advantage to using rituximab maintenance, and that's a recommended approach. Not all patients have very long-term remissions. One of the key genetic prognostic factors is TP53 status. This is a pooled analysis from the Nordic group looking at their clinical trials, demonstrating that if patients have a TP53 deletion or particularly a mutation, which is seen in about 10% of patients. They have an extremely poor outcome with the standard approach of immunochemotherapy and an autologous transplant, with progression-free survival very short and a median overall survival in the group that have a P53 deletion of approximately a year. You can see here, perhaps Kaplan-Meier curve F is the most striking here. You can see this is the cumulative incidence of relapse, and in the 20 patients with a TP53 mutation giving standard approach, nearly all patients had relapsed by two years. And this is a very strong independent prognostic factor for time to treatment failure in this cohort. So that's younger patients. Most patients would still be aiming to use rituximab and cytarabine in induction, give rituximab maintenance after an autologous stem cell transplant. I will talk about the triangle study shortly. In older patients, there are perhaps more options. This is an analysis of bendamustine rituximab versus R-CHOP in a German low-grade lymphoma nonHodgkin trial published some years ago, demonstrating an advantage here for bendamustine rituximab, although no maintenance was given in this subgroup of patients. Here is a study of R-CHOP versus VRCAP. So this is an R-CHOP-like regime where Velcade or bortezomib is replaces the zinc alkaloid, so the vincristine. And in this study, again, no maintenance in either arm. But you can see here a progression-free survival advantage to the VRCAP regime, and this is a nice approved regime. Although the uptake hasn't been huge, there's slightly more toxicity with this combination, more neuropathy, more thrombocytopenia, and more GI toxicity. So it hasn't been perhaps as popular as maybe this data might suggest it might be. There's also been a study by the European mantle cell lymphoma elderly trial group comparing FCR-based therapy versus R-CHOP. That's the first randomization in the study. The second randomization was between R-CHOP and interferon maintenance. A couple of important things to point out here. FCR really is no longer used in mantle cell lymphoma, partly because really this demonstrated quite a high treatment-related mortality, quite a number of deaths without treatment failure. And actually, if you look at the overall patient population, the overall survival was better for those receiving R-CHOP than RFC. This is partly due to the reduction in TRM with R-CHOP, but also due to the real marked improvement of progression-free survival when rituximab maintenance is used after R-CHOP. And so really this is the regime that's still available and used now, R-CHOP followed by R maintenance. You can see a median progression-free survival in this curve of 5.4 years. And so that still represents a reasonable option. So really options include bendamustine rituximab plus or minus maintenance, R-CHOP, VRCAP, or some other regimes in older patients that I'll talk about shortly. So just going back to the triangle study, as I said, I would mention now this isn't published as yet, and ibrutinib is not available routinely in the frontline setting. So in some respects, this remains experimental, but I think it's important to really just briefly talk about it. This was presented at the plenary session at ASH last year. So this is a three-way randomization, a large study by the European Mantle Cell Lymphoma Network, looking at younger, fitter patients who are suitable for autologous transplant. And patients were divided into arm A, which is the standard approach. So R-CHOP alternating with RDHAP, followed by an auto, followed by observation. I will add that rituximab maintenance became available during the study, and it was added into just over 50% of patients in each arm. It's pretty well balanced. The second arm here, so arm A plus I, is using the same backbone, but introducing ibrutinib with the R-CHOP in the induction, and then giving ibrutinib for 2 years of maintenance. And then the third arm, arm I, is probably the most interesting arm. So this is using the use of ibrutinib in the induction and as maintenance, but without the autologous transplant. There are various interesting statistical questions in this study, which I don't have time to go into at present. But in essence, here is the first readout of the study, so the failure-free survival. And it essentially demonstrates that when you use ibrutinib without the autologous stem cell transplant, the autologous stem cell transplant arm in blue is not superior to eye, so the ibrutinib containing arm without the autologous stem cell transplant. And that's the key first readout, that you can seemingly safely replace the auto by using ibrutinib in induction and then as fixed duration as maintenance-based therapy. Now, the analysis for the addition of the auto as well as the ibrutinib, so the auto plus ibrutinib versus the ibrutinib only arm, is still ongoing. We're waiting for a further readout here, but it doesn't certainly look like there's going to be any difference there. So the auto doesn't look to be adding anything when the ibrutinib is added as well. So we may well move to an era where we do not perform autologous transplant if we can access ibrutinib in the frontline setting, but of course that remains still an open question. Reassuringly, when you add ibrutinib to the induction, you don't seem to get additional toxicity. So I think that's really an important finding. But if you do use ibrutinib after an autologous stem cell transplant, so the A plus I group, you do get really substantially increased cytopenias and infection. So it looks like the balance of risks and benefits may well be with the ibrutinib induction without autologous stem cell transplant. But we await the publication of this data. Hopefully that'll be soon. And most importantly, the access to frontline BTK inhibition in this setting will clearly enable a change in the standard of care. And then the final group just to talk about in the frontline setting is the elderly patient group. So there's approximately 10 to 15% of patients who aren't suitable for standard dose immunochemotherapy. And so regimes that are still currently used are regimes like R-chlorambucil, R-CBP, perhaps attenuated BR or attenuated R-CHOP, although there remains no absolute clear standard of care. But this is a substantial minority of patients. Here's how these people do in routine clinical practice. This is a UK and Ireland analysis published a couple of years ago now, showing that on average you can expect a median progression-free survival of just over a year and a median overall survival of between 2 and 3 years. So really considerably shorter than the younger, fitter patients, with no clear winner in terms of the regimes that were studied in this retrospective series. Now, clearly, this represents an area of both clinical challenge and also unmet need. And so this is an area where certainly novel agents should be studied moving forward. In the auto-unfit patient population, BTK inhibitors have been brought forward and are being studied in a range of frontline clinical trials. I don't have time to go through all of these now. I've just summarized some of them here. We have seen the results of SHINE published. So there was a progression-free survival advantage for adding ibrutinib to BR, but the trade-off here of really considerably increased toxicity of ibrutinib in addition to BR didn't result in this being approved and broadly licensed and funded. BR plus ibrutinib and the SHINE study ultimately didn't reach the endpoint that was desired. Now, there is a study with the second generation BTK inhibitor, acalabrutinib, very, very similar design. We are waiting the readout of this. It'd be very interesting to see whether the slightly cleaner BTK inhibitor results in less toxicity in combination with BR. And then we have 2 non-chemotherapy-based approaches in the frontline setting, so ibrutinib plus rituximab and zanubrutinib plus rituximab. The enriched study will read out next year, and that's actually the readout is by time, so we will see that next summer. And the Mangrove study is still awaited. No maintenance in either arm in this study, interestingly. So we'll wait to see the results of that study as well. There are some novel agent studies ongoing, so taking a number of agents that we know to be active in mantle cell lymphoma and studying them in the frontline setting. I've just given 2 examples here. So the OASIS-2 study is an ongoing French and UK study analysing the benefit of the addition of venetoclax to a backbone of a CD20 antibody and ibrutinib. There are 2 stages to this study. The enrollment is ongoing, and hopefully we'll see some results from that. MRD at 6 months is the primary endpoint, which is an interesting primary endpoint, a number of key secondary endpoints. It's fixed duration therapy in both arms. And so this is a non-chemotherapy based approach across all ages. So a real shift away from this auto fit, not fit approach. And then another example here of a study from the US. This is a study from Memorial Sloan Kettering introducing this a similar triplet, but zanubrutinib, venetoclax, obinutuzumab. And this is looking at patients who are high risk with the TP53 mutation, clearly a group that need to be studied with novel agents. And you can see here, again, this is fixed duration, but it's MRD guided therapy, which is, again, an interesting and important concept to explore. So that's the frontline setting. We're still really in the immunochemotherapy era, but we'll probably move beyond that at some point relatively soon. What about relapsed refractory disease? Well, this is just a summary slide, really looking at our algorithm at present that exists. So in relapsed disease, a key question here is, are you suitable for CAR T cell therapy, and will you respond well or otherwise to a BTK inhibitor? Our BTK inhibitors are generally a standard of care at first relapse, and I'll talk more about the reasons why. And we have access to ibrutinib at first relapse. Now, in the US, actually, you can use CAR T second line, interestingly. So some centers will do that if you've got particularly poor prognostic features that means you won't respond well to a BTK inhibitor. But really, brexacaptogene autoleucel, the CAR T cell product that's available, is available in the third line setting in the UK, and I think it's generally considered to be broadly used before allogeneic transplant, although there's clearly some debate there. Following CAR T cell therapy or post allogeneic transplant, there's clearly no absolute standard of care, and there are various regimes that indeed could be tried. So here's a summary slide of the data that exists with ibrutinib, zanubrutinib, and acalabrutinib. So the three approved BTK inhibitors. Responses in relapsed refractory patients with a median age of about 65 to 70 show responses of between 68 to about 90%, so about 70 to 80% in most patients, with a median progression-free survival a little bit variable. Of course, some of these patients are much more heavily pretreated and higher risk, particularly the early ibrutinib patients, but somewhere between a year to up to 33 months with the zanubrutinib data. Infections and cytopenias are the most common toxicities seen. The analysis of various studies of ibrutinib were pooled, and you can see here in this pooled analysis that patients were analyzed according to the number of prior lines of therapy they had. And if you receive ibrutinib at first relapse as opposed to subsequent relapses, you can see an improvement in median progression-free survival, so 10.3 months versus 25.4 months. So this has led to NICE, at least, approving ibrutinib in this particular setting. And so you can expect a median of just over 2 years of benefit in that setting. Now, this is a slightly more tricky analysis, but there looks to be an overall survival, potentially a signal of overall survival difference. Of course, these patients are being treated much further along in their treatment pathway. So I take this data with a little bit of a pinch of salt, but it does look like if you use a BTK inhibitor earlier, it's a reasonably sensible thing to do. The depth of response is also higher if you use ibrutinib at first relapse as opposed to second relapse. So overall response rate is higher overall, but also the CR rate, which is the really key thing to induce durable remissions. As you can see here, if you attain a CR, you get approximately 4 years of benefit compared to a PR just over a year. So the depth of response is really key, and you'll receive more benefit, so higher rates of CR at first relapse compared to subsequently. But not all patients have durable benefit. As I mentioned, some consider CAR T in second line in the US, and it is these patients that's considered in. So the patients who have a blastoid morphology, their median progression-free survival on ibrutinib is only about 5 months. If you have a TP53 mutation, it's about 4 months with an overall response rate of only 55%. And there are also groups of patients who have a high Ki67, so a high proliferation index. This is data from an MD Anderson phase 2 study of ibrutinib plus rituximab, actually demonstrating that substantially worse overall survival if you have a high Ki67. Now, of course, there's clearly overlap between some of these patients, but these are the kind of features to be looking for at relapse when you're planning subsequent therapy, including potentially CAR T cell therapy subsequently. Now, there have been lots of attempts to improve on ibrutinib and BTK inhibitor use by adding a number of novel agents. I don't have time to go over all of this. This data is summarized in the review in Blood from a couple of years ago, but I would just state that you get additional toxicity when these agents are added in, and probably the combination that's in greatest development is a combination of BTK plus BCL2 plus or minus CD20. We're waiting a very important study readout called Simpetico, which was ibrutinib versus ibrutinib venetoclax, and that may potentially change the standard of care in relapsed mantle cell lymphoma. Following a BTK inhibitor, most people are considered, at least for CAR T-cell therapy, and it's based on the ZUMA-2 study that they're considered. So this took patients with relapsed refractory mantle cell lymphoma, bridged them with either continuing a BTK inhibitor or steroids, used a standard conditioning regime and a standard CAR T-cell dose. And primary endpoint was overall response rate with a number of key secondary endpoints. You had to have had a BTK inhibitor before, and most patients had chemotherapy and a CD20 antibody. Patients had a median of 3 prior lines and had quite a lot of high-risk features biologically, but were generally fairly young and fit. Here's the overall response result from the study. So a very impressive response rate in this setting with 2/3 of patients, so 68% of patients achieving a complete remission. And with long-term follow-up, we've certainly seen durable responses, particularly in those who have obtained a CR. So here are 46 patients who obtained a CR, and you can see this is the blue Kaplan-Meier curve for progression-free survival. The 2-year progression-free survival is 71%. So there are certainly patients who obtain very durable responses. I think it's a bit early to say these patients are potentially cured. I think we need much longer follow-up before we definitely say that. But certainly in this analysis, it looked like there were a number of patients with higher risk biological characteristics that did respond well to treatment. But as I said, I think we need a much longer follow-up and more data to understand which patients will benefit most. There's some US real-world data that suggests that response rates in high-risk patients are as good, but they do fall off and progress a little bit earlier than the overall population. So it may well be that those patients don't do quite as well. Now, this particular CAR T product does come with a bit of a kick to it. So 15% or so of patients had grade 3 or more CRS in the study. And I think probably most importantly, 1/3 of patients had grade 3 or more neurological events. So that's a substantial a number of patients developing really quite serious neurological toxicity. And I think that's a really important consideration when you're thinking about selecting patients for this clinical approach. So there is this question, of course, about whether CAR T or allogeneic transplant should be used first. And there was a big international recommendation published a couple of years ago now, taking a number of key groups from across the US and Europe, and really stated that if CAR T cell therapy is available, it should be considered before allogeneic stem cell transplant. And that remains the case. There are clearly some people who believe allos should be considered early in the treatment pathway, and particularly high-risk patients, and that's a very valid approach. But certainly the recommendations here is that CAR Ts should precede allo transplant where available. Okay, I'm just going to finish off now by talking briefly about the post-BTK space, and there are a number of investigational agents that are being studied here. So pirtobrutinib is a non-covalent, highly selective BTK inhibitor. It has excellent PK properties and is active in both wild type and C481 mutant BTK disease. This data is the pivotal data leading to the FDA approval of pirtobrutinib in mantle cell lymphoma. Overall response rates nearly 58% in a heavily pre-treated group of patients, all of whom had received a prior covalent BTK inhibitor, and most have had prior chemotherapy and CD20 antibody. Interestingly, the duration of response looks to be particularly good with this agent. Response rates clearly not as high as CAR T, but those that do respond do seem to gain durable benefit from this treatment. Progression-free survival, a median of 7.4 months in this study was observed. This is a very clean BTK inhibitor, and this is safety data from the whole clinical trial cohort from Bruin, demonstrating really minimal rates of grade 3 or more toxicity, low levels of treatment-related discontinuation, and very low levels of dose reduction. So it does look to be a very safe agent. And this agent is being brought forward into a randomized clinical trial setting in relapsed mantle cell lymphoma, where it's being studied against investigator choice covalent BTK inhibitor. So watch this space. This is a big global randomized clinical trial that's ongoing. Ro1 is an interesting embryonic protein that's expressed at birth, in utero and then lost at birth and then re-expressed on tumor cells. And VLS-101 is a Ro1 ADC, which looks to be potentially active in mantle cell lymphoma. This drug's been bought by Merck and is being studied in a big basket phase 2 study now. So watch this space with this drug too. Lysozyls are well-tolerated CAR T-cell products, also targeting CD19. We've recently seen this data presented actually in the summer congresses, so do take a look at that abstract. But efficacy looks fairly similar to Brexucell, with potentially lower levels of cytokine release syndrome and neurological toxicity. So we await the further development plan with this agent. And then finally, glofitamab is a drug that's in development. This is a T-cell engaging bispecific antibody with a novel 2-to-1 structure, targeting CD20 and CD3. It's been investigated in DLBCL and other indolent non-Hodgkin lymphoma. There's a typical ramp-up dosing schedule, as you can see here, and response rates in those patients that had been studied and exposed to a prior BTK inhibitor look very good. Relatively small numbers, of course, but the CR rates do look comparable to CAR T-cell therapy. So this agent's moving forward to randomized clinical trials in the post-BTK setting in relapsed mantle cell lymphoma. Cytokine release syndrome is a little bit more of an issue with mantle cell lymphoma. You often get circulating disease and so forth, and some of the other toxicities are noted, and we clearly need to gain more experience and understanding of bispecific antibodies as we do CAR T from a toxicity point of view. And with that, I'll finish, and thank you for your attention.
Hello, I'm Jessica Cosin, and I'm a CRUK clinician scientist and consultant hematologist at the Barts Cancer Institute. And today I'll be talking about follicular lymphoma. Thank you very much, Graham and Toby, for the invitation to come back and speak on the lymphoma management course. So let's start with some basic epidemiology in follicular lymphoma. As we know, this is the commonest indolent non-Hodgkin's lymphoma and accounts for about 20% of all non-Hodgkin lymphoma diagnoses. The median age of presentation is typically in the 60s, as you can see from the age-specific incidence curve. But the prevalence of this indolent lymphoma is much higher, with about 10 times the incidence of follicular lymphoma. So the great thing about follicular lymphoma, if we compare that with other lymphomas like the aggressive diffuse large B-cell or peripheral T-cell lymphoma, is that the outcomes have significantly improved. We now think about overall survival in terms of decades rather than years, and much of that improvement has come through the advent of chemoimmunotherapy, and the median overall survival now exceeds over 20 years. When patients present with follicular lymphoma, it typically presents with asymptomatic lymphadenopathy. Although we commonly think of B symptoms as synonymous with lymphomas, actually presentation with things like weight loss and night sweats are actually quite rare with follicular lymphoma. The presentation can be insidious. Sometimes this can be related to very large tumor bulk or lymph nodes growing in deep-seated areas. Things like mediastinal lymphadenopathy or CNS involvement is quite rare. However, bone marrow involvement occurs in over half of the patients at presentation. So once you've got a biopsy of follicular lymphoma, it has a very classical immunophenotype. So typically the things that we're looking for are pan B-cell markers such as CD19/20. They also highly express germinal center markers based on the cell of origin of follicular lymphoma. So typically you have CD10 expression as well as BCL6 expression. There is the pathognomonic chromosome translocation in follicular lymphoma, which is referred to as the 14-18 chromosomal translocation that leads to overexpression of the anti-apoptotic protein BCL2. So there's very high expression of BCL2. Important negatives such as CD5 negativity and CD23 are important to exclude other lymphomas like mantle cell or marginal zone lymphoma. FISH is actually not routinely done because the BCL2 expression is typically easy to detect by immunohistochemistry. However, when it has been done in studies, we typically see that about 85% of patients are positive for the 14-18 translocation in advanced follicular lymphoma, and the incidence is much lower and limited in early stage follicular lymphoma. Historically, grading was very important in terms of the histology, and this refers to the number of centroblasts within the high power field, and they were graded 1, 2, 3A or 3B, and this influenced the choice of treatment. So typically patients that were grade 1, 2, 3A were treated as follicular lymphoma, whereas those who grade 3B were treated as diffuse large B-cell lymphoma. It's important to say in the recent WHO update, the 5th edition from last year, a recommendation was that grading is no longer mandatory because aside from 3B, there is no other impact on treatment decisions. So what actually guides the choice of treatment of follicular lymphoma? So I think it depends on I would say three key things. Typically, it's a stage of disease, so it's discriminating between early versus advanced stage follicular lymphoma, the extent of the patient's symptoms, are they symptomatic versus asymptomatic, and other things to consider are the patient's other comorbidities, their fitness, and so on, and that will impact the choice of treatment. So let's start with early stage or limited stage follicular lymphoma, and patients, about 20% of follicular lymphoma patients will present with early stage 1 or 2 disease, and ideally this should be staged with a PET CT scan and bone marrow, because this is important to ensure that patients are not understaged rather than advanced, being staged as an advanced follicular lymphoma. The treatment options include radiotherapy alone, watch and wait, and rituximab. And the data for radiotherapy is essentially that, if patients that are treated with radiotherapy, about half of them are cured with radiotherapy alone. But we do know that a proportion of these patients will relapse afterwards, and typically when they do relapse, they relapse outside of the radiotherapy field. The other thing to say is that although radiotherapy is recommended in the guidelines, both in Europe and in the US, there has actually been very low uptake of radiotherapy use in the US. And I think this really stems from data that shows that if you use combined modalities like rituximab, together with radiotherapy or chemoimmunotherapy, that this leads to improved progression-free survival. It's important to say that despite these combined modalities improving progression-free survival, none have demonstrated superiority in terms of overall survival. So there is a risk that some of these patients may be overtreated, and obviously the consideration of long-term sequelae from chemotherapy down the line. So I think that the options that we have remain sort of radiotherapy. I think watch and wait is a very reasonable option, particularly if the lymph node has already been excised and the patient is asymptomatic. So we move on now to advanced follicular lymphoma. I think it's important to recognize that there is a spectrum or heterogeneity in clinical behavior. So the first patient timeline that you can see there is one that depicts this classic relapsing remitting clinical course. And here what we can see is that the patient's clinical history that spans over 25 years. This is a patient that I used to see in my clinic. And you can see that their clinical history is punctuated by numerous episodes of treatment as well as relapses over the course of 25 years. And then the other end of the spectrum are patients whose disease behave in a more aggressive manner. So these are patients whose disease progresses very early, even after contemporary chemoimmunotherapy. And in this case, this patient transforms within 2.5 years of therapy and unfortunately dies during the course of their treatment. So we're really trying to depict this kind of dichotomy in clinical behavior. Now, we have tried to sort of develop over the course of the last few decades to try and develop prognostic indices to try and capture this risk. So which patients are going to follow this very protracted clinical course and which ones are going to progress early. There have been a number of prognostic indices such as FLIPI-1, FLIPI-2, and more recently PRIMA-PI and FLEX. And these different indices incorporate a number of risk factors, clinical risk factors that can then allow you to segregate patients into 2 or 3 risk groups, usually low, intermediate, and high risk. As you can see that each of these indices some of them can predict for overall survival, some can predict for both progression-free and progression-free survival on overall survival. But one of the challenges is that none of these, whilst we record this information, none of these actually guide therapeutic decisions currently. So if we think about some of the treatment dilemmas that we have in frontline advanced follicular lymphoma, some of the questions that we have is, should we still watch and wait patients, particularly those that have low tumor burden? What is the optimal chemotherapy backbone? Does the CD20 monoclonal antibody matter? Should we give maintenance monoclonal antibody or not? And what about the option of being completely chemo-free in the frontline setting? So if we start with the first dilemma, should we still adopt sort of an active surveillance or watch and wait approach in asymptomatic low tumor burden follicular lymphoma? We got a number of studies, including a study by Adeshna and colleagues published in Lancet Oncology, probably almost about a decade ago now, demonstrating that whilst this was a randomized phase 3 study comparing watch and wait versus rituximab induction versus rituximab maintenance. And you can see here that there's obviously a significantly improved progression-free survival in patients that receive rituximab maintenance over those that followed a watch and wait approach. In addition to prolonging progression-free survival, it also increased the time to the next treatment. So what are the arguments for still continuing with watch and wait approach? Well, we know that actually treatment, regardless of whether they receive rituximab induction or rituximab maintenance or watch and wait, none of the treatments impacted overall survival. This did not improve over watch and wait. At 10 years, and this was recently presented at the updates at ASH last year, was that at 10 years, nearly 30% of patients still have not been treated for those in the watch and wait arm. And about 10% of patients undergo spontaneous disease reduction, not requiring therapy. However, what is a counter argument that patients should be treated is that, the median time to needing treatment for the watch and wait arm was 2.7 years, whereas this was not reached in the rituximab maintenance arm, suggesting that for patients that receive rituximab maintenance, it may be an option to delay chemoimmunotherapy, particularly in older, frailer patients, and this should certainly be a consideration over watch and wait patients. The other, of course, is the psychological impact and quality of life from not receiving treatment, so receiving the diagnosis of a cancer but not receiving therapy. So I would argue that both options, watch and wait and rituximab maintenance, are options for patients with low tumor burden follicular lymphoma. So for those that are, that are becoming symptomatic, what is the criteria for commencing treatment? We have a number of different criteria. We have the French GELF criteria as well as the BNLI criteria, essentially defining different definitions of tumor bulk, usually the presence of systemic symptoms, B symptoms, raised LDH, and the blood counts being affected are usually criteria to initiate treatment for a symptomatic advanced follicular lymphoma. So one of the dilemmas had been, for frontline follicular lymphoma, is an optimal chemotherapy backbone, and this was explored in a number of trials. The first was the Italian FOL-05 study, which was a randomized study comparing 3 different chemotherapy backbones, CVP, CHOP, and fludarabine mitoxantrone. As you can see, our CVP, which is in blue here, the curve in blue, was not as effective as our CHOP and RFM, but there was a 3-fold increase in secondary malignancies in the fludarabine mitoxantrone treated chemotherapy backbone. Following that, bendamustine came onto the scene, and we see this in 2 different clinical trials, the STILL trial and the BRIGHT trial, which compared bendamustine rituximab compared to our CHOP in the STILL study, and in BRIGHT compared to CHOP and our CVP. And you can see that in the BRIGHT trial, there was no difference between, that they had similar sort of response rates and PFS in the BRIGHT trial. The PFS was improved in the BR arm of this trial, suggesting that, that this really was, these 2 studies really put bendamustine as a chemotherapy backbone on the scene. There are different toxicities to consider between bendamustine and CHOP, and it's important to say in both of these studies that no maintenance was given. So what about anti-CD20? Is there one that is better, rituximab versus obinutuzumab? And this has the gallium. This was the gallium trial, and we've had the final updated analysis that was published last year. Just a reminder of the study design. This was a phase 3 randomized study in previously untreated follicular lymphoma patients. that were symptomatic, and they received obinutuzumab plus a number of chemotherapy backbones, CHOP, CDP, or bendamustine. And patients that achieved CR or PR then went on to have maintenance with the monoclonal antibody that they received at induction. And there are a number of primary endpoints, including the primary endpoint was PFS, as well as a number of other secondary endpoints. So in the final updated 8-year analysis, we can see that the progression-free survival for G chemo or O chemo, obinutuzumab chemo, were significantly better than R chemo, so 63.4% versus 55.7%. And this was also demonstrated to be significantly better for both EFS and time to next treatment. We can see that G chemotherapy shows a lower, in patients treated with G chemotherapy had a lower incidence of early relapse compared to R chemotherapy. And for those patients who achieved a complete metabolic response by PET scan, you can see also that patients that received G chemotherapy had better progression-free survival, both for those that achieved a CMR, but also for those that did not achieve a CMR. I think it's important to draw our attention to the fact that although we see this improved efficacy endpoints, that there are higher infectious complications with G chemo, there are higher infusion-related complications, as well as infectious-related complications. There is still no difference in overall survival. So the overall survival is similar between G chemo and R chemo, even at this prolonged final follow-up analysis. And the safety profile was, as you can see, very similar between both arms. So I think in terms of efficacy, certainly G chemotherapy had significantly better progression-free survival and time to next treatment compared to R chemotherapy. Things that we need to be thinking about when we are consenting our patients for some of these induction therapy, I think some short and long-term sequelae to consider. So if we're thinking about rituximab and obinutuzumab, things like viral reactivation is something that is very important for us to consider. So all of these patients should be screened for hepatitis B, C before commencing these monoclonal antibodies. They can also develop late onset neutropenia, things like hypogammaglobulinemia, and in the COVID area, we recognize that these reduce the vaccine efficacy. What about bendamustine? Myelosuppression is really important. Patients can become lymphopenic and stay lymphopenic for up to a year after receiving bendamustine. There is also a risk of secondary malignancies with bendamustine, and not insignificant, risk of about 10% of patients developing non-melanoma skin cancers like SCC and BCC. So it's important that they have very commonly, they should have a skin examination as part of their routine follow-up. There's also increased risk of opportunistic infections. And for both bendamustine and rituximab and obinutuzumab, we see that very rarely there is a risk of progressive multifocal leukoencephalopathy. So that's looking at induction. So what about the value of adding maintenance after first-line chemoimmunotherapy? And does that improve, is there value in adding that? So certainly the answer is yes, and this was demonstrated in the PRIMA study, which was a randomized study comparing rituximab maintenance to observation after induction chemotherapy. At the kind of 10-year follow-up, we can see that the median progression-free survival is significantly higher for those that receive rituximab maintenance, so median PFS of 10.5 years versus 4.1 years. And interestingly, even at the very prolonged follow-up, there appears to be no difference in overall survival in those that received rituximab maintenance over observation. There are some comments that I would make. In the PRIMA study, the majority of patients did not, in fact, no patients received BR as induction in this study. So it's unclear the value of adding maintenance in patients that have received BR or OB upfront, as many of our treatments in this current era are. And also PET was not used to assess end of induction response. So these are some important caveats from interpreting or extrapolating the PRIMA observations into this sort of contemporary era. So there have been some sort of, first iterations of using response-adapted approaches. So the FALL-12, which is an Italian phase 3 study, which really was trying to evaluate the efficacy of using this kind of response-adapted strategy following induction therapy. So in this study, what they did was after, this was a randomized phase 3 study where patients, after receiving induction therapy with either R-CHOP or BR, they either went down a standard or the standard approach, which is where these patients went on to have rituximab maintenance every 2 months for 2 years. And then in the experimental arm, depending on their PET end of induction response, whether they were PET, if they were PET negative and they were MRD negative by assessing for the 14/18 translocation. If they were PET negative and MRD negative, they went on to have observation alone, whereas if they were PET negative but MRD positive, they then went on to have 4 doses of rituximab. And then for those that were PET positive after the induction, they went on to have a combination of rituximab maintenance plus radioimmunotherapy also. So this is data here showing that very interesting data showing that patients in the experimental arm, which is the red curve, so arm B, that patients that were PET negative at the end of treatment actually had inferior outcomes in the experimental arm, including, and there is maybe a suggestion that those that are PET positive after induction, that they had slightly better outcomes with the experimental arm. But overall, this essentially was a negative study indicating that by response adapting with the treatments that have been suggested, that this did not improve outcomes in patients. So I think this is really just the first iteration of response-adapted clinical trial in follicular lymphoma. There are a number of other studies that are ongoing at the moment. So for example, in the UK, we have the PETREA study, which is a phase 3 study using PET-guided response-adaptive therapy in patients with untreated follicular lymphoma. And here the question that's being asked is, do we need maintenance in those who have had a good response to induction therapy? And in those with residual disease, so those that are PET positive, can their outcomes be improved with the addition of lenalidomide to the maintenance regime? So this is an ongoing study with patients being recruited in the UK and Australia. So the final question for the frontline setting is, can we move to chemotherapy-free combination? This was the question that the Relevance trial, which was an international phase 3 trial, which compared our chemotherapy to the experimental arm, which was R squared or rituximab lenalidomide. This was actually designed as a superiority study, but actually it demonstrated that both arms had similar progression-free survival. Both had very similar outcomes. And so R squared was essentially comparable to our chemotherapy. There are different kind of safety profiles to consider based on the toxicity profiles of lenalidomide. You certainly see more cutaneous reactions in the R squared arm, and there were more neutropenias as expected in the R chemotherapy arm. So what is our take home and in terms of the summary frontline treatment in advanced follicular lymphoma at this stage in 2023? I think certainly the data continues to point towards still that anti-CD20 plus chemotherapy remains the standard first line therapy. I think options in terms of chemotherapy backbone are certainly BR, bendamustine rituximab, certainly R-CHOP. There may be a preference to reserve CHOP chemotherapy for those that are transformed. RCVP certainly is, in terms of progression-free survival, certainly inferior to these first 2 modalities, but it's still an option. And as I mentioned, that most would favor a bendamustine backbone. I think rituximab maintenance, as shown from the PRIMA trial, does improve progression-free survival, but there's no difference over survival. There remains questions about whether there is a role of maintenance even in patients that have received a bendamustine induction, and that question hopefully will be answered by the PETREA study. It's certainly clear that obinutuzumab chemotherapy or G chemotherapy is more effective than R chemotherapy, but again, no difference over survival. In the UK, we have this approved for patients with follicular lymphoma with FLIPI scores of 2 or more. I think it's also important when we're having these discussions with our patients to think about what the goals of our treatment are. And I think that it's important to recognize that in choosing therapies, we're obviously trying to maximize efficacy whilst reducing the risk of relapse transformation and obviously limiting short and long-term toxicities and also consideration of the patient's quality of life. So if we now move to relapsed follicular lymphoma, I think This is just, some curves from the gallium trial. And you can see that in the majority of patients, so we become quite accustomed to progression-free survival of probably in the region, a median PFS of probably in the region of 8 to 10 years after frontline therapy. Unfortunately, the same can't be said for subsequent lines of therapy. So after second-line treatment, the median progression-free survival is incredibly short. It's in the region of a year to 18 months for most patients. So there is a lot to do in the relapse refractory setting. So we can see that most patients with follicular lymphoma will relapse, and when they do relapse, the progression, the treatments that we have available really keeps the patient's disease-free for a very short period of time. It's also important to say that not all relapses are alike. There are a group of more high-risk follicular lymphoma patients, so those that progress very early, their so-called POD, or progression of disease, within 24 months after induction therapy. These patients have a significantly poor outcome. So you can see here the 5-year overall survival of just 50% compared to 90% for those that relapse much later. This is probably in the region of about 15% of patients who experience this early progression. The other high-risk group of patients are those that transform to aggressive lymphoma, typically diffuse large B-cell lymphoma. And again, as you can see, this is data from the Aristotle retrospective study that demonstrates that when patients transform, the 5-year overall survival, again, is significantly worse, 43%. And if this transformation occurs early, that impacts the survival even more. So we have a plethora of treatment options in the relapse refractory setting. We've got conventional therapies, repeating chemoimmunotherapy again, rituximab monotherapy, radiotherapy, transplant, and then of course there are lots of new kids on the block in terms of targeted therapies and immune therapies. The challenge that we have is that there is no consensus approach for relapse refractory follicular lymphoma. How we sequence the therapies, what orders we give therapies in is also, we know, is particularly important, but it's unclear how we should do this. So what I think is really heartening to see is that there have been a number of drug approvals in relapse refractory follicular lymphoma. So if we although this is not on the curve, so rituximab was approved for relapse refractory follicular lymphoma in 1997. And so if we look down 25 years later, there have been a number of approvals in this space. And I've highlighted here where the drugs that are available, that are FDA approved, so available in the US, and those that are available in Europe. So you can see a whole range of different classes of drugs, targeted therapies, as well as immunotherapies in more recent times that have been approved in relapse refractory follicular lymphoma. So these are the targeted therapies. You can see one chemoimmunotherapy that has been approved. There have also been CAR T cells that have been approved for transformed follicular lymphoma, so relapse refractory transformed follicular lymphoma. And in red here are just drugs that have been approved in the UK, that is available to us in the UK. So what do we need to think about when we're approaching a patient who we suspect has relapsed refractory follicular lymphoma? I think the first thing to do is certainly take a biopsy to exclude aggressive transformation, because the treatment is different. And then the next question is really a decision about, does the patient need treatment at all, and what are goals of our treatment? And the things that we need to consider are both kind of patient-related factors, what do they have, certain specific comorbidities, their performance status, their own preferences, obviously availability of treatment depending on the region that you're in. And then, of course, there are a number of treatment-related factors to consider. What were their prior therapies? What was the quality and duration of the response? I think it's important to say that the choice of therapies for relapsed refractory lymphoma is still is not really dictated by the biology or the tumor-related characteristics currently, but this may change in time. Okay, so what are the options available in second line and beyond? So obinutuzumab bendamustine with maintenance is approved for patients that are rituximab refractory follicular lymphoma, and this came about from the Indolent randomized phase 3 study. In this study, patients that were it enrolled patients that were rituximab refractory, and they were randomized to receive either obinutuzumab bendamustine or single agent bendamustine for up to 6 cycles. And then patients who achieved at least stable disease went on in the experimental arm to have obinutuzumab maintenance. The primary endpoint was progression-free survival. As you can see, that those in the obinutuzumab bendamustine arm had a significantly better progression-free survival of about 29 months, so probably about 2.5 years for patients. And also there was an improvement in median overall survival. So really presenting this as a very credible option and the reason for the approval of obinutuzumab bendamustine. One of the questions that we have in this more contemporary era is it is unclear the efficacy, particularly now that many of our patients in the front line are receiving R-bendamustine or O-bendamustine. It's a really data-sparse zone. We have no idea whether patients who have had prior treatment with a bendamustine backbone would also be whether they would receive the same efficacy as patients who had not received bendamustine previously. So I think this is an open question in the field. What other options are available? We've also got R-squared or Len-R. This is a kind of a non-chemotherapy option that is approved in the second line and beyond setting. And this comes from data from the Augment phase 3 study. This was a study in patients with relapsed follicular lymphoma, but important to say that patients were not rituximab refractory, or they didn't have to be rituximab refractory to be enrolled into this study. And they were randomized to either Len-R, which they received for up to a year, or our rituximab placebo as the control arm. The primary endpoint was progression-free survival, and as you can see, the median PFS in the Len-R arm was significantly better than patients receiving single-agent rituximab, so 39 months versus 14 months, and the rates of a histologic transformation was much lower in the R-squared arm. Again, I draw attention to some, comments, particularly one of the challenges, of course, is the comparison with the control arm. Is rituximab alone an appropriate standard in relapsed refractory follicular lymphoma patients? It certainly is in a subset of patients, but probably in a more contemporary era, and there are many more options available. And because this trial recruited primarily patients that were not rituximab refractory, it was unclear how effective this combination would be in high-risk cohorts. I think that question has been mostly answered from emerging data from the Magnify trial, which is an ongoing randomized phase 3b trial, which is looking at R-squared versus R maintenance in rituximab refractory follicular lymphoma patients. And what we can see from the kind of interim analysis from the Magnify study, which included patients that were rituximab refractory, but also a number of high-risk patients that had early relapse, like POL24. We had patients that were double refractory from rituximab as well as alkylator agents. We can see that the progression-free survival in these patients, the median progression-free survival, is still pretty high, indicating that Len-R or R-squared can be a very good option for both rituximab sensitive as well as refractory patients, as well as other high-risk cohorts. So certainly Len-R, a very effective treatment combination for a range of relapsed refractory patients. I'm not going to dwell too much on transplant. So the question is, where is the place of transplant in this era of lots of targeted and immunotherapies? I'm just going to draw attention to data on autologous stem cell transplant for early progressed follicular lymphoma, and this is data from 2 studies. The first is the CIBMTR LymphoCare study, which essentially evaluated. This is a retrospective data looking to see the value of high-dose therapy and stem cell transplant. As you can see here, patients that received a stem cell transplant had a better 5-year overall survival compared to those that did not receive a transplant. And these are patients with early relapse. And again, this is a retrospective study from the German, this is from the pooled data from a couple of German studies. And again, they had a number of patients who had early progression. And you can see here that for those that had POL24, for those that received a transplant, an autologous stem cell transplant, they had better 5-year progression-free survival compared to those who did not receive a transplant. It's certainly outside of the sort of the early progression setting, it's clear that there is a diminishing role of both autologous and allogeneic stem cell transplant, particularly with emergence of novel therapies. I bring this up just to kind of raise some questions, really, but also some observations. So PI3 kinase inhibitors we had 4 FDA-approved PI3 kinase inhibitors in relapsed refractory follicular lymphoma, although not in the UK. This was available as a third-line and beyond option for patients with relapsed refractory follicular lymphoma. And this really stems from the fact that there was a very strong biological rationale for targeting the cell receptor signaling pathway in follicular lymphoma. And across all of these 4 different PI3 kinases, they mostly target the delta isoform of PI3 kinase, and the majority of them come in oral formulations, with the exception of cupanlisib, which is IV. They had a number of really, serious adverse events, which, what these sort of delayed immune-related toxicities that are associated with this sort of first generation PI3 kinase inhibitors that are typically given continuously. I think the take-home message in terms of efficacy, they've all got very similar efficacy, response rates of about 40 to 60%, median PFS of about a year, but they are really affected by these very high adverse events, and as a consequence of that, last year several of these PI3 kinase inhibitors were actually withdrawn in the US. So it's really difficult to see where the place of PI3 kinase inhibitors will be for relapsed refractory follicular lymphoma. So if we look at some of our existing guidelines in the UK and in Europe, this is what we have: recommendations to consider a clinical trial, especially for early progression. The options can be observation alone if they're asymptomatic. For those that are early progressors, if they're younger and fitter patients, to certainly consider high-dose therapy and stem cell transplant based on those, as you can see, based on data from those retrospective studies who had better outcomes with transplant. Chemoimmunotherapy can be repeated if they've not had it previously, or if they had a very long remission with a prior chemoimmunotherapy. And those that are rituximab refractory, obinutuzumab bendamustine is an option. These, as you can see, these guidelines were about 3 years ago, and since then we've had this emergence, tsunami of new therapies that have been approved. In Europe, LEN-R is also a recommendation in older patients, as well as rituximab monotherapy. And then there was talk about considering PI3 kinase inhibitors, but consideration of the toxicities. So let's move to some of the newer therapies. So, CD19 CAR T cell therapy in relapsed refractory follicular lymphoma. There are a number of studies, and a number of them have been FDA approved. So if I show you the data on Axicell, which was from the ZUMA-5 trial, these were in relapsed refractory patients who had at least 2 prior lines of therapy. And typically, I'm just showing you what would happen in these patients. They're typically leukapheresis, and then they have lymphodepleting conditioning chemotherapy, usually fludarabine, cyclophosphamide, and then they have infusion of the CAR T cell, in this case Axicell, on day 0, and then a number of primary endpoints, overall response rates, and then a number of secondary endpoints as shown here. And what I've done here is just to show you some back-to-back data. So we have a number of CD19 CAR T cells. So we have Axicell and we have Tezacell, and these were in 2 studies. So in ZUMA-5, it evaluated Axicell, and in the ELARA study, they evaluated Tezacell. The follow-up in these studies, and these were published last year, is still very short. You can see here a median follow-up of about 17 months. But what's really impressive, you can see the overall response rate of 94%. This is probably the highest response rate you will probably ever see in the relapsed refractory setting in follicular lymphoma. Very high CR rates as well, 79, between 70 and 80%. But we can see that there continues to be a difference in outcome for those that have have early progression. So those that have early progression have a significantly lower progression-free survival and response rates, is shown in both studies. At ASH last December, there was updates to both of these CD19 CAR T studies. So at 41-month follow-up, we can see that the 36-month progression-free survival has dropped a bit. So we're now in the region of just over 50% of patients. And indeed, in the ELARA study, we can see the 24-month event-free survival at about just over 50%. So I think the question is CAR T potentially curative in a subset of patients. Is it still, where is its place? Should it be in third line, or should it be brought higher up? These are questions that are going to be evaluated in the coming years. And I think that POD24 patients, early progressors or high-risk patients, still continue to be a challenge. Now, I think we've always thought of CAR T as a kind of the jewel in the crown, so to speak, but I think there are a number of competitors. There are obviously challenges with CAR T in terms of, the cost of manufacturing, the timelines, the toxicity. I didn't mention this, but obviously they have a high rate of cytokine release syndrome and neurotoxicities. And of course, some of these limitations also means that the access for patients is quite narrow. And then bispecifics, I think, is certainly going to give CAR T a run for its money in follicular lymphoma. There are advantages of bispecifics antibodies because they're typically off the shelf, and this may allow broader access, and the toxicity profile is certainly better than CAR T cells. So just to remind people, bispecific antibodies, they work by essentially dual targeting, both by engaging the tumor cells, but also bringing the T cells into the vicinity of the tumor cells. And there are a number of CD20, CD3 bispecific antibodies. We're also starting to see CD19 and CD3 bispecific antibodies that are being evaluated. There are a number of them that are being evaluated in follicular lymphoma at the moment. The 5 that I've highlighted here, they come in different configurations, some that have 1-to-1 binding, so they have 1 CD20 binding and 1 CD3 binding, and some that have 2-to-1 binding, such as glofitamab over here. The efficacy and toxicity data of bispecifics in relapsed refractory follicular lymphoma looks very impressive. So mosunetuzumab, for example, which is an IV formulation that is given up to 17 cycles, we can see from the sort of early phase data over response rates of 80% and 60% CR, and a PFS of about 18 months. Most of these bispecifics compared to CD19 CAR T cells have much lower CRS, or grade 3 to 4 CRS, usually in the region of about 1 to 2%. And as you can see, that all of these bispecifics have very impressive early response rates. And the follow-up in most of these studies is still very short, so it remains to be seen what the median PFS will look like. A number of bispecific combinations are already being evaluated also. So this is a space to really watch, and already mosunetuzumab has been FDA approved as of last December. So what's the challenge that we have? I mean, what is the optimal sequence in the relapse refractory setting? I think we don't have a formula for this at the moment. Typically, what we do as clinicians is we look at the data in terms of efficacy, duration of response, and we compare that or balance that with the toxicity of these therapies and the quality of life, how it might impact the quality of life of the patients. We can see there are a number of options in the second-line setting, many options in the third-line and beyond setting. And I think one of the challenges why it has been difficult to define an optimal sequence in the relapse refractory space is that typically we have risk stratifying tools upfront of diagnosis. For example, we have FLIPI upfront and Prima PI, but we don't have any in the relapse refractory setting that can allow us to stratify patients, with the exception of POD24. So we know that these are certainly a high-risk group of patients. Also, one of the challenges is that there's a real paucity of randomized comparisons. Most of these relapse refractory drugs that have been approved have mostly been approved from usually phase 2 studies without comparison. So these novel options haven't been compared to standard relapse refractory options. The other challenge also is that the frontline treatment is evolving. I mean, we can see that the chemotherapy backbone is evolving, the anti-CD20 could be evolving, and this in turn will influence the choice of what we give to our subsequent second line and beyond therapy. And I think I know it's strange to be able to say this, but actually we've get to a position where there might be too many options. There's several different CAR Ts, there's several different bispecifics, lots of different combinations. And also one of the things that we really lack is we don't really know what is the biological impact of prior therapy. So, for example, does prior chemotherapy impact T cell fitness? Will that then in turn impact the efficacy of later bispecific or CAR T cell therapies? And we don't really have predictive biomarkers that tell us who will respond and who is resistant. So in conclusion, where are we in terms of frontline therapy in follicular lymphoma? So for limited stage, I think excision plus or minus local radiotherapy, as this is potentially curative in about 50% of patients, is one of the main options. Observation alone is reasonable if the lymph node has been excised and the patient is asymptomatic. What about advanced stage follicular lymphoma? For those with asymptomatic low tumor burden, I think watch and wait continues to be reasonable, but we must remember that rituximab maintenance actually prolongs the time to next treatment. For those that are symptomatic, chemoimmunotherapy followed by maintenance continues to be the primary option. We can see from these studies that also that there's evolution of both the chemotherapy and the anti-CD20 in terms of improving progression-free survival. In terms of relapse refractory follicular lymphoma, there's a rapid succession of options, lots of novel therapies in relapse refractory follicular lymphoma. I think main challenges that remain is how to choose, and I don't know if there will ever be a standard for relapse refractory follicular lymphoma. However, we are in a really uniquely privileged position where there are many drugs on the horizon, and we're beginning to see in the relapse refractory setting that there is an evolution towards less chemotherapy and more immunotherapy cellular therapies. And on that note, thank you very much for listening.
Good evening. I'm Kim Linton from the Manchester Cancer Research Centre, and I'm delighted to provide you with some updates on the management of marginal zone lymphomas, with a big thank you to Toby and Graham for inviting me to this series. As you all know, these are mature B-cell lymphomas arising from memory B cells, frequently in the context of infection or autoimmunity. They are the third most common lymphoma, accounting for just over 2,600 cases per year in the UK, with an increasing incidence, largely due to the fact they disproportionately affect older patients. The median age in the UK at diagnosis is 72 years. Like all the indolent lymphomas, they are incurable, but they follow a very indolent clinical course, and the 5-year survival is good, approaching 80%. The WHO classification recognizes 3 distinct subtypes: extranodal, the most common, splenic, nodal, making up 20 and 10% respectively. There are also about 5% of patients who present with clonal B-cell lymphocytosis, which is genetically linked to splenic marginal zone lymphoma, but very rarely transforms into splenic marginal zone lymphoma. And importantly, in the latest classification, they've separated out primary cutaneous lymphomas, originally classified as extranodal, and pediatric nodal lymphomas, originally classified as nodal marginal zone lymphomas. Now, the general workup involves a biopsy and peripheral blood immunophenotyping, classically showing the repertoire of B-cell antigens, CD5, CD10 negative, cyclin D1 and MYD88 negative, and almost all cases presenting with surface IgM positivity. In the latest BSH guidelines, we've recommended a bone marrow biopsy only in the splenic marginal zone lymphoma subtypes and in the other subtypes if there's early stage disease or cytopenias. Staging typically involves a CT scan, which is the standard of care, but increasingly PET scans are used, and this is definitely okay and should definitely be done in patients with suspected transformation or early stage disease. And the Lugano classification is most commonly used. Blood tests should be performed routinely, including serum protein electrophoresis, virology for hepatitis C, which is etiologically linked, and then, if indicated, a number of other tests according to the presentation. Now let's look at the individual subtypes. So gastric malt makes up half of the extranodal marginal zone lymphomas, and so is the most common lymphoma that we encounter in clinical practice. And almost all of these tumours are driven by Helicobacter pylori. You can typically see a polypoid lesion on endoscopy, which is also quite useful for mapping and photographing the lesion. The Helicobacter species can be detected by immunohistochemistry, as well as a number of other tests, and importantly, we can pick up Helicobacter pylori as well as other species. And all patients with gastric malt should have FISH looking for MALT1 gene rearrangements, because this is a clonal marker for resistance to Helicobacter pylori eradication and also a marker of a more aggressive clinical course. Now, the non-gastric malts can arise from mucosal-associated lymphoid tissues at many sites, and they are also sometimes associated with a number of infections or with autoimmune disease. And we're increasingly recognizing that there are site-specific genetic alterations, but fewer recurrent translocations than seen in gastric mold. And when patients present with non-gastric mold, there might be some site-specific investigations that are relevant to perform. Now, when we treat these mold lymphomas, as I say, gastric mold, typically driven by H. pylori, should be treated with Helicobacter pylori triple eradication therapy in all cases. So that's regardless of stage or presentation. So that's typically a week of triple therapy with a stool or urea breath test at 6 weeks to assess response, and an endoscopy at 3 to 6 months. And remember, some of these responses can be quite late, but really the CR rates are impressive at over 60% with triple eradication therapy alone. And do this even in patients who have negative H. pylori tests, because it could be a false negative. Involved site radiotherapy is appropriate for patients with early stage disease or those who have failed antibiotics, and you can get away with 24 gray to produce very high complete response rates. Low dose radiotherapy is also entirely appropriate in the palliative setting. For patients who present with advanced stage disease, if they are asymptomatic and have low tumor burden disease like follicular lymphoma, you can very comfortably watch and wait, as there is no disadvantage to overall survival for delayed therapy. And really, it's those patients with symptomatic advanced stage disease or failure of local therapy or relapse disease for whom systemic therapy is indicated. Now let's walk through some of the evidence, starting with multiple lymphoma. And the only randomized phase 3 study ever performed in this disease was the ILSG-19 study, which convincingly demonstrated that the combination of R-chlorambucil was more effective than chlorambucil or rituximab alone, producing a progression-free survival of over 70% at 5 years. So this is really the standard of care for the majority of patients because it is well tolerated. But in situations where patients can't tolerate the combination or are too frail for the combination, monotherapy is appropriate, particularly as there is no survival advantage for the combination. Now, whilst the ILSG study didn't include any maintenance, a subsequent study with the same inclusion criteria, the ILSG-38 study, showed that you could further improve progression-free survival by adding a 2-year maintenance course. So that improved PFS from 72% at 5 years to 87% at 5 years. Now, many people also like to use RCVP for patients with multiple lymphoma. And again, there's some evidence from a couple of phase 2 clinical trials looking at RCVP with and without a 2-year maintenance phase, showing a progression-free survival of around 60% at 3 years without maintenance and 80% at 3 years with maintenance. Now, while these figures might look a little less good than the data for R-chlorambucil, these studies included all patients with advanced stage disease, and they also included a third of patients with nodal marginal zone lymphoma, which could have affected these outcome data. But it is really difficult, of course, to compare clinical trials one to the other. For younger patients, MDTs will often recommend rituximab and bendamustine based on data from the phase 2 Geltamo study from the Spanish group, which showed very impressive 7-year progression-free survival exceeding 90% for the combination of rituximab and bendamustine. Now, the further advantage of this combination is that patients who achieve a CR after 3 cycles only need to have 4 cycles of therapy, and there is also no maintenance phase. So this is very short course therapy, but it is potentially more toxic with 5% febrile neutropenia rate. So really selection should be applied, and it may not be the best option for some older patients. Now let's look now at splenic marginal zone lymphoma, which typically can be diagnosed from a combination of clinical features, peripheral blood morphology, and peripheral blood or bone marrow flow cytometry. So these patients present with massively enlarged spleen, bone marrow involvement, cytopenias, and sometimes lymphocytosis with these characteristic villous lymphocytes in the peripheral blood. But the important distinction here is that nodal involvement is exceedingly rare, with the exception of the splenic and hilar lymph nodes. And then immunohistochemistry and flow cytometry will distinguish them from the other marginal zone lymphoma subtypes, with important reference to immunoglobulin D, or IgD, which is positive and distinguishes it from the other subtypes. Hepatitis C is implicated in splenic marginal zone lymphoma in up to 16% of cases and should be routinely looked for in all cases. And this is important because treatment with hepatitis C antiviral treatment can lead to spontaneous regression. Splenectomy historically has been the treatment of choice for these lymphomas, with a 3-year progression-free survival of 90%, but this is invasive surgery, and its practice has largely been replaced by novel agents in the modern therapy era, with the exception of patients with massive splenomegaly and minimal bone marrow disease or lymphadenopathy, where it still has a role to play. Watch and wait can lead to 30% of patients untreated at 10 years and should be an option for patients with asymptomatic, advanced stage low tumor burden disease, and again with systemic therapy reserved for those patients who are symptomatic, progressively cytopenic, or who have compromised vital organs or bulk disease. Now, the data for rituximab monotherapy come from a couple of retrospective studies, again looking at rituximab as a short course of rituximab in combination with a maintenance phase, producing very impressive 9-year data with a progression-free survival of 76%. And so that's just 6 weekly infusions with 2 monthly maintenance for 1 year. Importantly, maintenance, like the other indolent lymphomas, improves PFS but not overall survival. So there is some discretion that can be applied when selecting your patients for maintenance. And if you look at the table that we're putting together here, you can see rituximab and maintenance looks to compare favorably compared to splenectomy. Now, again, rituximab and bendamustine is a preferred option potentially for younger patients, and data here come from the ILSG36 BRISMA clinical trial, which was a phase 2 study showing a progression-free survival of 90% at 3 years for patients receiving rituximab and bendamustine. And like the MALT lymphoma study, patients can get away with just 4 cycles if they achieve CR, and there is no maintenance phase. But again, this is still a toxic therapy, or more toxic than some of the other options, with 9% of patients in this study stopping due to toxicity. And really, there is still an open question about the added value of bendamustine over rituximab monotherapy in splenic marginal zone lymphoma, with some quite compelling data coming from a retrospective study in just under 1,000 patients, specifically looking at this question in older patients. So the population had a median age of 78, and as you can see from the Kaplan-Meier plots, there was no event-free survival or overall survival advantage for adding bendamustine to rituximab in splenic marginal zone lymphoma, and the increased toxicity offset the survival benefit. So certainly in my practice, I offer even younger patients rituximab initially and reserve BR for those who've failed. Now, the nodal marginal zone lymphomas, the rarest of the marginal zone lymphoma subtypes, are typically diseases that present with disseminated but non-bulky disease, and crucially don't have splenic or extranodal involvement. They can have bone marrow and a leukemic phase, and the associations with autoimmune and hepatitis C as described. Sometimes quite difficult to diagnose from the other marginal zone lymphoma entities, and definitely have a prognosis that's inferior to the other subtypes. And their treatment really follows similar paradigms to follicular lymphoma. But the one thing I would like to draw your attention to is the outcome of the marginal zone lymphoma subset enrolled in the Gallium clinical trial, which, as you know, showed a PFS advantage for obinutuzumab chemotherapy over rituximab chemotherapy in the follicular lymphoma subset. Now, they didn't show that advantage in the marginal zone lymphoma subset, with a similar PFS of 75% at 3 years in both treatment arms, but there was also increased toxicity, so higher grade 3 to 5 adverse events, with 12% fatal adverse events in the obinutuzumab chemotherapy arm. So that suggests that it possibly is too toxic for marginal zone lymphoma, although do remember that this subset included 71% treated with bendamustine, and that may have been part of the reason for the inferior outcomes or poorer tolerance in that group. Certainly, obinutuzumab chemotherapy is not something I give to my patients with marginal zone lymphoma, but obinutuzumab is still under investigation in marginal zone lymphomas in general. Now, although frontline therapy is very active, most patients, if they live long enough, will undergo a relapse of disease, and the treatment paradigms are very similar to the first-line setting. There are a number of novel agents coming through. This slide summarizes some of the more active agents with the largest number of patients, and what you'll notice is that there were some PI3 kinase inhibitors previously approved. These have now largely been withdrawn from the clinical market and from clinical trials due to safety concerns, leaving us with the BTK inhibitors, rituximab and lenalidomide, and I'll also talk briefly about axi-cel. So the B-cell receptor is intact in marginal zone lymphoma, and B-cell receptor signaling is implicated in the pathogenesis and progression of this disease. So targeting BTK has really been a game changer in this disease. The Magnolia clinical trial, which recently reported its results, demonstrated a progression-free survival of 83% for zanubrutinib monotherapy in relapsed and refractory disease, which compares favorably to the ibrutinib data, the first-generation BTK inhibitor, but follow-up for the Magnolia study is still short. What I think is most impressive about the Magnolia data is that there was consistent efficacy across all subtypes and all age groups. And this is particularly important because many of our patients are too old to tolerate immunochemotherapy. So zanubrutinib provides a very effective and well-tolerated option for these patients. And certainly zanubrutinib is in ongoing investigation in many clinical trials. Now, the data for rituximab and lenalidomide combination come from subset analyses of the Magnify and the Augment clinical trials, which demonstrate an impressive progression-free survival with a median PFS of 41 months in patients with marginal zone lymphoma. Interestingly, the added benefit of lenalidomide over rituximab was not demonstrated in a subset analysis of the Augment clinical trial. It was the only subset that had a hazard ratio of 1. So there is still some uncertainty as to the true value of adding lenalidomide to rituximab, but nevertheless, it looks like an active option and is something that can be obtained on compassionate grounds in the UK. And finally, there are a subset of patients, younger patients with early treatment failure for whom a more intensive therapy may be considered appropriate. And here are some data from the ZUMA-5 clinical trial looking at axi-cel in 20 patients with marginal zone lymphoma. As you can see, the drug is active, but less active than it is in follicular lymphoma, with perhaps a somewhat disappointing median progression-free survival of just 12 months in the marginal zone lymphoma subset. And this may be related in part to the toxicity profile of axi-cel, which produced quite high rates of neurological toxicity in this study, with almost 40% of patients experiencing grade 3 or higher toxicity. So I think it is an important area for study, and the ongoing Lysocell study, the Transgend study that's enrolling marginal zone lymphoma, is potentially going to be offering a safer CAR-T therapy for these patients, and time will tell when we have the results of that study. And so finally, I just want to draw your attention to the very busy space of ongoing trials in marginal zone lymphoma, which is very exciting to see, particularly the vast array of targets that are being looked at in this disease area. And I'd like to draw your attention particularly to the ILSG48 clinical study and the Mahogany clinical study, because these are studies that the UK is going to participate in. So ILSG48 is a randomized comparison between rituximab, zanubrutinib, and rituximab monotherapy in first-line splenic marginal zone lymphoma, and Mahogany is a randomized comparison between rituximab zanubrutinib and rituximab lenalidomide in patients with relapsed disease. And importantly, that's an access route for these novel therapies because we don't currently have them available in any other format in the UK. And finally, I'd really like to encourage you to read the latest guidelines for the diagnosis and management of MZL, which we've just published through a BSH hematology guideline. This is a very comprehensive review of the subject, and I'd encourage you to take a look at that. So with that, I'd like to thank you very much for listening to my talk.
Good evening. My name is Jay Moore-Katari. I'm a consultant hematologist in Oxford, and I'm delighted to be here to talk to you about Waldenstrom's macroglobulinemia. I'd like to thank Lymphoma Action for organising this superb course, and to my consultant colleagues in Oxford, Graham Collins and Toby Eyre, for asking me to talk to you about this fascinating lymphoma. So Waldenstrom's, in essence, is a lymphoplasmacytic lymphoma in the bone marrow, together with an IgM paraprotein of any size. It's a rare lymphoma with approximately 350 new cases in the UK, and it is a disease of the elderly, with the median age of diagnosis being around 70 to 75. It was first identified in the mid-40s by the Swedish hematologist Jan Waldenstrom. So the bone marrow has a very characteristic appearance in Waldenstrom, where you have a dual infiltrate of lymphocytes and plasma cells The plasma cells have very characteristic immunoglobulin inclusions, and there are mast cells often liberally seen throughout the bone marrow. Because there is a paraprotein to measure in the blood, the precursor state IgM-MGUS has been very nicely defined and characterized over the last few decades. And longitudinally following patients with IgM-MGUS shows that there is a low rate of progression to either asymptomatic or symptomatic Waldenstrom's, with most progression happening in the first 10 years following diagnosis, and most patients die of unrelated causes rather than progression to a symptomatic disorder. A nice way of thinking about the way in which Waldenstrom's can cause problems is through the model where you think about the B cell component and the plasma cell component. The B cell component is often the cause of symptoms relating to tumor bulk, anemia, B symptoms, lymphadenopathy, and splenomegaly, whereas the plasma cell component causes symptoms attributable to the M protein, things such as hyperviscosity syndrome, neuropathy, which is typically a demyelinating neuropathy, hemolysis, or the paraprotein can have cryoglobulinic properties as well. Immune deficiency can lead to problematic infections, also driven by the plasma cell component. Because people have serum electrophoresis done for so many reasons, we're increasingly picking up more patients with not only IgM-MGUS, but also asymptomatic Waldenstrom's. Some nice work done in the States a few years ago now looked at the reasons why people may progress, and they showed from a big cohort analysis that typically things such as marrow infiltration of greater than 70%, beta-2 microglobulin of greater than 4, which is often a surrogate for this, a low albumin, and an IgM of greater than 45 are independent risk factors for progression. There's a very nice calculator available freely on the internet where you can calculate the patient's risk of progression. What is also clear is that patients without the MYD88 mutation are also more likely to progress more quickly, but mutational status was not in the work that has been done with regards to the patient risk calculator. So MYD88 L265P mutation in Waldenstrom's was first characterized and described around 11 years ago now by Prion and his colleagues from Boston. And what we know is that MYD88 mutation leads to constitutive activation of important cellular machinery, leading to the activation of Bruton tyrosine kinase, which then leads to further phosphorylation of kinases that essentially lead to pro-survival instincts in cells in Waldenstrom's. Our understanding of this system has allowed the development of highly effective therapies, and certainly we'll be talking about BTK inhibitors in some detail in a few minutes. What we know is that MYD88 mutations occur in over 90% of patients with Waldenstrom's. CXCR4 mutations occur in around 40% of patients with Waldenstrom's. There are more types of mutations, and what has become clear is that patients with CXCR4 mutations can have a more aggressive course with a higher IgM at presentation and symptomatic hyperviscosity. They are more likely to have high-grade transformation, and they are less responsive to covalent BTK inhibitors. Because MYD88 L265P is so prevalent in Waldenstrom's, it's made diagnostics of Waldenstrom's and related disorders much more simple than perhaps it was in decades previously. It's important to note that patients with IgM myeloma do not have a MYD88 mutation, be it IgM myeloma is rare. There are approximately 10 to 15% of patients with splenic marginal zone lymphoma who have a MYD88 mutation, but typically the immunophenotype and clinical presentation makes the differentiation between WM and splenic marginal zone relatively straightforward. MYD88 mutations are also seen in ABC-type diffuse large B-cell lymphoma and also primary CNS lymphoma. So in many patients, Waldenstrom's is an indolent condition. It's a disease of the elderly. So it's really important to understand what happens to survival in these patients and whether they're competing risks of death. And what has been shown in big registry data is that many patients die of non-WM related causes. In this cohort of patients, of around 6,000 patients diagnosed between 1991 and 2010, only a third of patients died of lymphoma-related reasons. This is newer data from 17 cancer registries, and this is a combination of patients with WM and also non-IgM LPL, again, highlighting, especially as people get older, that non-WM related deaths become extremely prevalent. And that's really important when thinking about how and when to treat these patients. So once we have a diagnosis, the key thing is, do they have asymptomatic or symptomatic disease? Smoldering Waldenstrom's is monitored and not treated, and patients should be followed up intermittently, IgM measured together with clinical examination and regular blood work. If a patient is symptomatic, key questions are, what are the patient's comorbidities? What are their preferences? And how quickly does disease control need to occur? And the two choices are fixed duration chemoimmunotherapy versus continuous therapy, which is BTK inhibitors. There are standardized indications for the initiation of therapy, which are highlighted in this slide here. I would like to comment in a little bit of detail about hyperviscosity, because hyperviscosity, I think, is still poorly understood. Symptomatic hyperviscosity is a clinical diagnosis. The symptoms can be vague. They can include a headache, cognitive vagueness, nosebleed, visual disturbances, headache. But irrespective of the IgM level, if a patient is symptomatically hyperviscous, that should be treated. As a general rule, patients should not be plasma exchanged to reduce the IgM quickly on the basis of a plasma viscosity result alone. There is varying practice around this. Some people have exchanged patients when they have a viscosity over 4. This is generally not recommended, and there is poor data to support that approach. The only occasion in which we tend to exchange asymptomatic patients, they have an IgM greater than 40, and we're considering using rituximab. If you use rituximab in a patient who has a high IgM, they can get the phenomenon of IgM flare, whereby WM-related symptoms, and especially neuropathy, can get worse. Different IgMs in different patients will lead to different plasma viscosities in vivo, and there can be a difficulty in really extrapolating an actual IgM level and a viscosity to how that actually makes the patient feel. Important work done by colleagues at the Mayo have highlighted that development of symptomatic hyperviscosity at any time point does not impact overall survival, and it's very rare to be symptomatically hyperviscous with an IgM that is less than 30. WM is rare, and as we start looking at some of the data over the next 10 minutes or so, it's important to remember that some of the studies are small, some are oligocenter, and they may not represent the patients that we see day to day in routine practice. Because there is a paraprotein to measure, as well as imaging findings, we assess response to treatment, essentially combining paraprotein response and imaging response. And there are very standardized approaches to this, which are highlighted in this slide. So in terms of fixed duration chemoimmunotherapy, rituximab combinations are very well established and extremely effective. Rituximab and bendamustine and cyclophosphamide dexamethasone and rituximab are the commonest 2 combinations that are used. Bendamustine rituximab is very effective at rapid cytoreduction and is used more in younger patients. There are a group of patients whereby cyclodex and rituximab is very effective treatment because it's so well tolerated with very little infectious complications and still does offer durable disease control with a median PFS of 2 to 3 years. Often DRC, as we call it, is very good treatment for patients who progress with slowly progressive anemia as the reason for them needing to start treatment. Proteasome inhibitors are also very good, but not available in the UK for use, and they also cytoreduce and reduce IgM quickly. There is a limited role for single-agent rituximab, but not for agents such as chlorambucil or purine analogs anymore, and there is no data supporting the use of rituximab maintenance. So what about BTK inhibitors? So the first data came naturally with ibrutinib, which was now published 7 years ago, highlighting that ibrutinib is really a very effective agent in relapsed Waldenstrom's, with the group of patients who seem to benefit best having a single MYD88 L265P mutation. And in that group of patients, you have a really impressive major response rate in this study of 97%. Interestingly enough, patients with a CXCR4 mutation, which is a smaller group, the major response rate is significantly less. And these patients definitely with a single agent BTK inhibitor have a shorter progression-free survival. This is highlighted nicely in this cohort of over 300 patients treated with ibrutinib, highlighting that the patients that do the worst in this setting from a PFS perspective are those that have a CXCR4 mutation and have a platelet count that's starting less than 100. It was natural to see whether adding rituximab to ibrutinib would provide additive benefit, and that was done in the Innovate study. The majority of patients in this study were relapse refractory and was essentially a randomized study between ibrutinib, rituximab, and single-agent rituximab. The results are perhaps not surprising. Addition of rituximab did not lead to a significant increase in toxicity in any way. Sometimes in these studies, I do find the control arm informative because actually you're getting an 18-month median PFS with rituximab alone, which is not bad for a low dose and a low risk intervention. With regards to the adverse events relating to continuous treatment, after year 1, there were significantly less adverse events, and around 12 patients had grade 3 or grade 4 atrial fibrillation in this study. So the question is, well, who really needs rituximab with their BTK inhibitor? This is a little bit busy, this PFS curve, but what it actually highlights is that mutational status makes no difference if you're on single-agent rituximab, which is to be expected. But the patients who may benefit from additional rituximab in this setting are patients who have a CXCR4 mutation. So what about different covalent BTK inhibitors? We have zanubrutinib and acalabrutinib. There is a very nice randomized study of zanubrutinib versus ibrutinib called the Aspen study. Both these agents are highly effective, as can be seen from this PFS curve. There was more CR and VGPR observed with Zanu, but this was not statistically significant. There was no different overall survival in this study either. So I suppose the question is well, why would you use one over another in this setting? And clearly in the CLL field, there's been a lot of work, but we understand the toxicities of covalent BTK inhibitors as well. And certainly with ibrutinib, we do worry, especially about atrial fibrillation, hypertension, diarrhea, and arthralgias. So if in a head-to-head study, you can show that there is less toxicity with an alternative agent, then it may be beneficial to use this agent. And that is what we did see in the Aspen study. AEs were seen in both arms, unsurprisingly, but there were significantly more discontinuation AEs with ibrutinib. And as you can see from this slide, the AEs that we worry about with ibrutinib, there was a lot less seen with zanubrutinib, essentially very little atrial fibrillation with zanubrutinib, less hypertension. You do see more neutropenia with zanubrutinib, and that's an important point to remember when using this agent. So a summary of the covalent BTK inhibitors is that there is superb efficacy with all of these agents in Waldenstrom's. Acalabrutinib is never going to have a license, so I haven't gone into that study in any detail. Zanubrutinib has a better toxicity profile than ibrutinib, so if both are available, I would generally recommend using zanubrutinib, and that's the only one we have available in the UK. And there may be a group of patients with CXCR4 mutations who it may be worth adding rituximab to if you can. This is a study just highlighting that if you do get toxicities with covalent BTK inhibitors such as ibrutinib or acalabrutinib and you swap to zanubrutinib, there may be less adverse events than if you change the agent. And essentially what this slide shows is that if people had adverse events and then they changed to zanubrutinib, that the majority of the AEs did not recur, and that's the blue lines. Some recurred at a lower grade, which is the green bar, and only a minority recurred at the same grade. But I think you could do studies like this, in the other direction as well. And I think the important point to make is if you have access to more than one covalent BTK inhibitor in Waldenstrom's and patients are intolerant, do try a different one. So what do we do following covalent BTK inhibitor failure? There is no standard of care. Certainly, you can retry chemoimmunotherapy if the patient is not refractory. We talked about changing BTK inhibitors, and there is some interesting data coming out with non-covalent BTK inhibitors. There is a small but very limited role for autologous stem cell transplantation in younger patients, but the ESMO guidelines, I think, correctly recommend that this is not done prior to a patient has been exposed to a BTK inhibitor. There are a number of clinical trials ongoing, looking at combinations of BTK inhibitors, proteasome inhibitors, and other agents. The data may not always be applicable to what we can access for our patients with Waldenstrom's. What we do have in the UK at the moment is the Rainbow study, which is an upfront study comparing DRC to rituximab ibrutinib. I don't think anyone thinks that the PFS is not going to be better, of course, with rituximab and ibrutinib, but I think we're going to see some very interesting data with regards to quality of life and the metrics of what happens continuing ibrutinib long-term in a more of a real-life multi-center population, which the Rainbow study certainly has, and it's recruiting extremely well. There is some data telling us what happens when you discontinue ibrutinib in Waldenstrom's, and I think that the essence of this smallish study, but nearly 200 patients, highlight that patients do respond to salvage treatment, and again, it's the patients with the CXCR4 mutations that tend to come off the ibrutinib sooner. So just very quickly before I close, this is a little bit of data on LOXO 305 pirtobrutinib, where in their initial study, there was actually a cohort of 80 Waldenstrom's patients with 63 with prior covalent BTK inhibitors, which is actually bigger than the initial study with ibrutinib. So for WM, this is a big study. And this is really quite impressive data. This is patients that, 63 patients who had been exposed and either discontinued due to either progression or toxicity, but you're seeing a major response rate of 67% with a nice tolerability profile. And I think we're going to be hearing more about this agent in Waldenstrom's, and also there are other non-covalent BTK inhibitors that are in clinical trials. So in summary, now that we understand the disease biology better, it has paved the way for easier and more precise diagnosis. But because it is a disease of the elderly and many patients die from non-WM related reasons, the choice, type, and duration of therapy are crucial. Fixed duration rituximab-based chemoimmunotherapy is tolerable, effective, and it is fixed duration. For continuous therapies, side effect profile is really very important. Low-grade toxicities for many years is not something we should really be exposing patients to if we can avoid it. There are many more choices in the BTK space, and we're going to see a lot more data on these agents. And I haven't had time to talk about the rare manifestations of a rare lymphoma today, but they can remain difficult to not only treat, but also identify, such as CNS involvement or so-called Bing-Neal syndrome, anti-MAG neuropathy, acquired von Willebrand disease, and there is, of course, non-IgM LPL, which we broadly treat in the same way. If you are interested in WM, please do read this very nice guideline published early last year, which goes into all of this in a lot more detail. Thank you very much for your attention.